Good morning, everyone, and welcome to the UCT-Africa case presentation. My name is Matthew White, and I'm a registrar here at the University of Cape Town. Just before we get started, just some of the usual house rules. Everyone can please keep their microphones muted for the duration of the talk. If you have any questions, please use the chat function, or you can ask them at the end of the talk. Just the usual brief disclaimer: I've written consent from the patient to publicly share their clinical details and photos on this platform. All my content is referenced. We jump into the case. It was a case of a 65-year-old male who presented with a 7-month history of progressive dysphonia. Specifically, had no associated dysphagia, aspiration, loss of weight, or hemoptysis. He had multiple risk factors in terms of squamous cell carcinoma. He had a significant background of 30-year history of smoking. Also used alcohol on a regular basis. He was good performance status, ECOG 1. He had also had a good effort tolerance. He was a retiree living alone with his wife and was a non-professional voice user. Technically, he was an elderly male. He had a dysphonic, hoarse, rough voice. He had no associated stridor. On examination of his neck, he had no associated lymphadenopathy in the laryngeal spheres and was grossly normal. Assessment of his respiratory system was unremarkable, and his lungs were essentially clear on auscultation. Flexible endoscopy, nasal endoscopy was done, which revealed a small extrahepatic tumor limited to the anterior third of the right true cord, with extension onto the anterior commissure, and the vocal cords were mobile. He was clinically assessed at that point as a T1A N0 glottic lesion. Chest X-ray was done, which showed no evidence of metastases, and he had bilateral hyperinflated lung fields in keeping with his background of smoking. The staging, rigid laryngoscopy and panendoscopy was done, which was essentially in keeping with our initial assessment. Subsequent biopsy revealed an infiltrating, well-differentiated keratinizing squamous cell carcinoma. He subsequently underwent a tumor board discussion and counseling, at which point he chose to embark on surgery, and subsequently went to theatre and had a type 5A chordectomy, which included resection of the anterior 2/3 of the right true cord, his anterior commissure, and a segment of the contralateral anterior true cord. The following day, he was eating well in our ward with minimal pain. He was mildly dysphonic, not much worse from his preoperative state, and had no stridor and was discharged home. So, despite this being a relatively straightforward case, I've chosen to present it to discuss the significance of the anterior commissure involvement in early glottic carcinoma, and attempt to discuss the controversies which surround it, and in so doing, address the following questions. Firstly, where is the anterior commissure and how does one anatomically define it? Does it require any further special investigation? Does it pose any surgical or oncological challenges? What is its prognostic significance in terms of oncological and functional outcomes? And should it ultimately be better reflected in the current AJCC TNM staging? So just before we move on to the specific controversies regarding the anterior commissure, I just want to clarify a few key points, which I'm sure we are all aware of in terms of the general principles of management of early glottic carcinoma. Firstly, we're specifically referring to a localized or early disease, specifically AJCC T1 or T2 disease, or prognostic stages 1 or 2. And I think we'll all agree that whichever management option is chosen, these patients should ideally be managed and counseled in the context of a multidisciplinary team involving a minimum of a head and neck surgeon, an oncologist, a speech and language therapist, and ideally, where possible, other allies such as a dietitian or a radiologist, possibly even a pulmonologist and social worker. It's well established that in the treatment of early stage disease, and it is essentially laryngeal conservation, which through a single modality treatment, one aims to preserve laryngeal function whilst at the same time offer an excellent oncological chance of cure. Specifically, therapy which maintains all aspects of laryngeal function, domains of voice, and open airway independent of tracheostomy and swallowing without significant aspiration. The current literature recognizes that both transoral laser microsurgery or primary radiotherapy can achieve this goal. And also historically, this would further include open partial laryngectomy procedures such as a laryngophysiocordectomy or vertical partial laryngectomy, which may still be acceptable and resource constrained in certain settings. In terms of the management of the neck, the rate of occult nodal disease is extremely low at 7%. Therefore, no elective neck dissection or radiotherapy is recommended or required. In terms of comparing our two main modalities, radiotherapy and laser microsurgery, this is controversial with multiple nuances in the literature in support of each modality. But broadly speaking, the prognosis in terms of local regional control and disease-specific survival are comparable at in excess of 95% for T1 disease and at more than 80% for T2 disease, with some literature reflecting a lower rate of laryngeal preservation with radiotherapy, with generally comparable voice outcomes, and again with a few kind of nuances in terms of voice outcomes. Generally speaking, laser microsurgery offers the following advantages. It's cost effective to both the patient and the institution, and this has been illustrated in multiple cost utility studies. It's practical as day case surgery with an expedited recovery, short hospital stay, and a low side effect profile. These aspects have been reflected in studies such as the Easter trial. And it's further supported by studies which have shown that up to 20 to 30% of initial biopsies are essentially curative in early disease, and where subsequent resection or biopsy has revealed no residual invasive malignancy. It facilitates accurate pathological staging, which is further important for prognostication and assessing the need for any adjuvant radiotherapy. And in the event of local recurrence, one has a repertoire of options, including repeat laser resection, various forms of partial laryngectomy, or even total laryngectomy, and of course, radiotherapy. Disadvantages include obviously the initial setup cost of the equipment, the surgical learning curve, the need for general anesthesia in patients at high risk, possible difficult transoral access, and further that patients require reasonable pulmonary reserve, which is important usually for more advanced resections where patients may have to tolerate temporary or even a permanent degree of aspiration. Broad advantages in terms of radiotherapy include avoidance of general anesthesia in high-risk patients or in cases of poor transoral access, and possibly better voice outcomes with involvement with lesions of the anterior cord and anterior commissure. Disadvantages include a minimum of 6 weeks of therapy, long-lasting side effects ranging from mucositis, dysphagia, xerostomia, airway swelling, and chondroradionecrosis, just to mention a few. And furthermore, post-radiation edema and tissue changes may make clinical surveillance challenging in terms of assessing for early recurrence clinically. In cases of treatment failure, salvage, as we know, is challenging and inevitably results in salvage laryngectomy in most cases. As I mentioned earlier, some studies have reflected a lower laryngeal preservation rate with radiotherapy and the long-term risk of radiation-associated malignancy, which is particularly pertinent obviously in patients. Open partial laryngectomy options for early glottic carcinomas include laryngophysiocordectomies or other forms of vertical partial laryngectomy, or rarely a supracricoid laryngectomy. These procedures offer excellent comparable oncological outcomes in terms of survival and local control. However, they're rarely performed due to being associated with less predictable and logically poorer functional outcomes in terms of phonation and swallowing without aspiration and tracheostomy independence. So according to the current TNM, the anterior commissure is stated as a subsite of the glottis, but it does not include any definition as such, and there's no universally agreed anatomical definition that I can see in the literature to define its exact boundaries. And I must say, the more I've read about its anatomical descriptions, the more confused I've become. So practically speaking, the anterior commissure can be considered as a clinical concept used to describe the anterior part of the glottis, measuring approximately 1 millimeter in width and 10 millimeters in length. And it's where the true vocal ligaments converge anteriorly as the fibrous Broyles tendon and insert onto the inner aspect of thyroid cartilage. It's further considered to be in continuity, or in some texts at least in close proximity to the insertion of the thyroid glottic ligament. Similarly, its role in facilitating or resisting tumor spread is a subject of debate. The anterior commissure tendon itself is thought to be intrinsically resistant to tumor spread due to its fibrous and avascular nature, resulting in a low incidence of less than 20% of early glottic tumors involving the anterior commissure. However, it's been postulated that it may represent an anatomical weak point facilitating early cartilage invasion, which has been hypothesized to be due to several factors. Firstly, the thyroid cartilage is devoid of its inner resistant perichondrium at its insertion point. Secondly, in addition, at its insertion, the mucosa or epithelium of the vocal ligaments at the anterior commissure tendon is in closer proximity to the thyroid cartilage than anywhere else. If you think about it, at every other laryngeal subsite, there's either muscle or paraglottic space, or at least perichondrium between the laryngeal cartilage and the surface mucosa. And thirdly, a local inflammatory response in early tumors in close proximity to the anterior commissure has been postulated to result in ossification of the thyroid cartilage, which has been thought to facilitate tumor invasion and create a weak point as such. Its close proximity to the thyroepiglottic ligament and epiglottic petiole further facilitates early spread into the pre-epiglottic space, which of course, as we know, is in continuity with the paraglottic space. Its close proximity inferiorly to the cricothyroid membrane also allows for potential early extralaryngeal spread through the cricothyroid membrane space. So if we look at the role of imaging in anterior glottic carcinoma, now knowing the patterns of spread and invasion, it makes sense that much of the concerns regarding imaging are directed at the early detection of invasion of the thyroid cartilage, the pre-epiglottic, paraglottic space, and pre-laryngeal soft tissues. This is obviously important because it's with upstage patients to T3 or T4 disease, depending on the degree of invasion, where invasion of the inner cortex of the thyroid will upstage to T3, and invasion of the outer cortex with or without extralaryngeal soft tissue involvement will upstage to T4A disease. However, having said this, in our unit, we do not routinely image our patients with clinically early glottic carcinoma involving anterior commissure, but rather adopt the philosophy of Steiner and Ambrosch, where we follow the disease during the laser resection as required, if we've decided to embark on transoral laser microsurgery. However, one must also obviously keep in mind that this is under the guidance of Professor Fagan, who's obviously an extremely experienced laser surgeon. And therefore, if you're a less experienced laser surgeon, imaging may be beneficial in terms of knowing what you're getting yourself into. And it may also further play a role in patient counseling. Here in our unit at Prognostic, we're more likely to perform imaging in a patient with anterior commissure involvement who is considering radiotherapy first line, where if extensive cartilage involvement is found on imaging, we would counsel the patient on the risk of chondroradial necrosis and potentially poorer oncological outcomes should they still want to proceed with primary radiotherapy in the presence of significant cartilage invasion. Similarly, where cartilage involvement is found on imaging, as we mentioned, the patient will be upstage and will invariably need adjuvant chemotherapy if primary radiotherapy is to be considered. Some units will routinely or rather reflexively do CT scanning of the chest and possibly the abdomens to screen for pulmonary or other distant metastases. And therefore, some might argue, well, why not just include the neck at the same time? Again, it's not our protocol for us here to screen further than with the simple chest X-ray. And this is based on studies such as those above, which show significantly low risk at less than 1% of pulmonary metastases in early glottic carcinoma. And in fact, the risk of a second primary lung malignancy may in fact be higher. And we therefore do not screen further for metastases unless the chest X-ray is suspicious. If we move on to comparing modalities in terms of imaging, most studies compare CT with MRI. In a meta-analysis and systematic review, it was found to have MRI, was found to have superior sensitivity in the detection of cartilage invasion at 88%, compared to CT scan at 66%. Both modalities were comparable in specificity at 88 and 81%. And other advantages of MRI include its excellent negative predictive value in detecting cartilage invasion and superiority in assessment of the pre-epiglottic space, the paraglottic space, base of tongue, subglottic extension, and soft tissue invasion. Generally speaking, disadvantages include its high cost, its slow acquisition time, inevitably long waiting lists, and its pure dual assessment of distant metastases, particularly lung metastases due to motion artifacts. Ultrasound is an often forgotten imaging modality, with a few studies assessing its utility in original carcinoma. In one of the studies I came across, it illustrated an excellent accuracy at detecting cartilage invasion at 88%, which was in fact superior to MRI at 85%. Other obvious benefits include that it's cheap, that does not require the risks of contrast, and it's obviously more readily available. And just as a final comment on imaging, I'd just like to emphasize that all studies regarding these imaging modalities are done in academic centers of excellence, the capabilities of your local radiologist. Obviously, your results are only as good as your own ability or your local radiologist's ability to interpret these investigations, and your choice of imaging should obviously be tailored appropriately. So if we look at the impact of anterior commissure involvement on the practical aspects of surgery, I think we'll all agree that it's a challenging area to visualize and work on. Challenges with access can be predicted by the usual factors associated with poor visualization, including a reduced hyoid mental distance, incisor gap, the dental status of the patient, macroglossia, micrognathia, limited neck mobility, previous neck surgery or radiotherapy, high Mallampati scores, and a high body mass index. Techniques described in the literature to improve visualization and access to anterior commissure include removal of the shoulder roll and moving the patient from extension into the voice Jackson or slipping position, with which the neck and slight flexion straightens the C-spine and potentially improves visualization of the anterior commissure or anterior larynx. Cricoid pressure can be provided by an assistant or by downward pressure applied by strapping anchored to the bed. And the use of specialized anterior commissure scopes of various types, which generally have a more acute angle or triangular shape, can be used, or distending laryngoscopes like the Steiner or Weirder diverticular scope can also be tried. Alternatively, the microscope can be substituted substituted for angled endoscopes and combined with handheld flexible laser guide fibers. And there are obviously newer studies exploring the role of transoral robotic surgery. But ultimately, if you can't oncologically safely resect the disease, one should admit defeat, wake the patient up, and consider radiotherapy, or alternatively, referral to a more experienced laser surgeon. Once, and I suppose if the anterior commissure has been adequately visualized, one can proceed with the laser resection. However, as I mentioned earlier, these are challenging cases for the experienced laser surgeon, where patients most often require a type 5A cordectomy with excision of the involved vocal ligament, the anterior commissure, and the anterior contralateral cord, as in our case study. Our approach to the anterior commissure, again, as I said earlier, is based on the work pioneered by Steiner and Ambrosch. Our excision is planned as in the top right image from the Brewer UCT-Chapter on CO2 laser microsurgery. And once mobilized by the above series of planned incisions, the tumor is stripped in a plane deep to the inner thyroid pericardium. And if no further erosion is identified, the tumor bed is sterilized by defocusing the laser, as in the bottom right image. However, if there's deeper cartilage invasion of the tumor, it's chased and may require full thickness excision of the cartilage, even up to just deep to the skin, or alternatively, it can be combined with an open laryngofisher excision. The use of frozen section is described. However, we do not use frozen section for laser excision in our unit. Webbing of the anterior true cords is a well-described complication of resection involving the anterior commissure, especially for T1B disease involving both cords. Laryngeal webs are generally associated with poor outcomes in terms of phonation, and where severe may cause upper airway obstruction. In many cases, it's largely unavoidable, but some surgeons will stage the resection, initially resecting one side and returning 1 month later to resect the contralateral side. Once established, the web cannot merely be divided, as the rate of refusion is unacceptably high. Techniques used to surgically address established webs include division of the web, followed by temporary lateralization with a suture, or the use of a temporary keel, and some surgeons will apply topical mitomycin as an adjunct to this. Traditionally expensive preformed silicone stents or silastic keels have been used. However, in a study conducted by Dr. McGuire and Professor Fagan, they demonstrated that a keel fashioned from inexpensive brown general merchandise tape was safe and equally as effective to the silastic keels and stents. If we move on to looking at the overall impact of anterior commissure involvement of laser surgery, in a retrospective review by Stevenson and Fagan, a study was conducted to assess the significance of anterior commissure involvement on outcomes in laser microsurgery. The study included a total of 76 patients managed by a single surgeon with disease ranging from carcinoma in situ to T3. 30 of the patients had anterior commissure involvement, and the results of the study revealed that anterior commissure involvement was associated with an increased rate of uncertain or positive margins at 63% versus 30%, and that patients with anterior commissure involvement were more likely to receive adjuvant radiotherapy at 40 versus 3%. Both groups had excellent comparable rates of laryngeal preservation at 96%. And on the basis of these findings, it was concluded that laser resection with the use of adjuvant radiotherapy in patients with adverse pathological findings can be recommended for the treatment of early glottic carcinoma with anterior commissure involvement, with excellent local control and laryngeal preservation rates. And just to show that this wasn't just a once-off, other similar studies have shown excellent comparable outcomes in terms of laryngeal preservation. So based on the earlier mentioned challenges in the previous slides in terms of surgery, should we rather just submit patients with anterior commissure involvement to the alternative option of primary radiotherapy? This again is obviously a point of controversy, with several publications suggesting that anterior commissure involvement is associated with a poor response to radiotherapy. In a meta-analysis of the local control rate of early-stage laryngeal carcinoma managed with radiotherapy, it revealed inferior control rates with the involvement of the anterior commissure at 55 to 80%, versus 82 to 90% where the anterior commissure was not involved. However, other studies have provided conflicting data indicating that anterior commissure involvement is not necessarily associated with poor local control rates. Reasons mentioned for possibly poor oncological outcomes include the potential for increased occult or missed cartilage invasion or a clinical understaging rate of up to 40%. And there's further a risk of underdosage at the air tissue interface due to the superficial proximity of the anterior commissure, leading to poorer coverage of the prescribed dose, where some oncologists are advocating for an increased dose by a factor of 2 gray for this subsite. So again, as I mentioned, there are obviously no randomized control trials comparing laser surgery to radiotherapy for the treatment of early glottic cancer involving the anterior commissure. But the above study is one of the larger retrospective case series of a total of 54 patients with T1 glottic carcinoma with anterior commissure involvement, where outcomes were compared between 38 patients who received radiotherapy and 16 patients who received laser. And the outcomes between the two groups are illustrated in the table. Essentially, what it showed is that logically, laser was associated with a higher recurrence rate and a lower disease-free survival. But unfortunately, the laryngeal preservation rates are not compared, which would probably be more meaningful. And both groups had excellent overall survival at 78.9% for radiotherapy and 87.5% for laser. And interestingly, when they did a subgroup analysis comparing the outcomes between T1A versus T1B disease, both groups had similar outcomes. So in terms of voice outcomes in early glottic carcinoma with anterior commissure involvement, it must obviously be emphasized that despite voice being an important aspect, it should not be prioritized above oncological outcomes. Multiple meta-analyses and systematic reviews have been done to directly compare outcomes between radiotherapy and laser in early glottic carcinoma in terms of voice, with most studies supporting that for small mid-chord lesions requiring a type 3 chordectomy or less, long-term measures of voice outcomes are comparable at 1 to 2 years. No studies have directly compared these modalities in terms of anterior commissure involvement, unfortunately. But it's logical that involvement of the anterior vocal ligaments and anterior commissure would result in inferior voice outcomes, especially where large resections are required. In a study by Peretti et al. Looking at the voice outcomes following type 5 chordectomies, which is the usual minimum surgical requirement for anterior commissure involvement. At 2 years, the majority of patients at 82% had subjectively mild dysphonia, and less than 20% had moderate dysphonia on the voice handicap index score. And the last study I'd just like to end with is the following study published recently in the Laryngoscope in 2019 by Tully and colleagues, which through systematic review and meta-analysis assessed the prognostic value of anterior commissure involvement in T1 glottic carcinoma. It involved 16 studies and a total of 4,341 patients. 84% of their patients were treated with radiotherapy and 16% with laser microsurgery. The study confirmed that anterior commissure involvement is a negative prognostic factor in local control at 5 years, associated with 12% overall reduction in local control, and specifically a 23% reduction in T1A disease and 13% in T1B disease. And on this basis, the authors of the study appealed to the AJCC staging committee to reflect the anterior commissure's negative prognostic impact on the T staging. And this sentiment has subsequently been reiterated in other papers. So in conclusion, watch this space, as it still remains a point of considerable controversy and may be taken into account in future staging systems. But despite all its hype, it's only one of multiple factors which may or may not influence the choice of treatment. And just to re-emphasize that all decisions should be individualized in the context of a multidisciplinary team, taking into account the usual patient, tumor, or disease, and institutional factors. And that's the end of my talk today. Any comments?
I think that's an excellent presentation. Just to give you some historical perspective, so when I was training the registrar and our CT scans weren't really good. If you had an anti-commissure tumor, even with a T1 patient with a because there was always concern about cartilage invasion, so that's what the standard practice on the clinics. And then, but then some would do an intralateral vascular laryngectomy for them. And so that's historically where we were. You must also be careful to interpret the results of radiotherapy, and radiotherapy techniques improved a lot over the years. So if you put all the studies, they have real problems with the dosages like anterior, just below the skin. So that's just a caveat there. I think you highlighted the issue that when you're looking at outcomes of early glottic cancer, you can't really look at 5 years survival, but rather at laryngeal preservation. That should be probably your outcome measure. And so my approach really is that you look at the patient, if it's a teacher or someone who's really dependent on the voice, you have to discuss the fact that if you operate at the anterior commissure, you end up with a voice. So sometimes they might trade off perhaps a lesser local control rate to maintain voice, so that's an important issue to consider. I do image some of them, but if it's a small lesion, I don't see any benefit. But if it's a larger tumor which is really plastered down on the anterior commissure, then I think imaging is important. Also to find those cases where the tumors escape into the soft tissue anterior to the neck. But the small ones, I don't see any benefit because certainly you strip, as you said, the tumor in the subperiocondylar plane, and you see what's happening. That's going to be more sensitive and specific than imaging. And if you then find that it's gone through the pericondylar into the cartilage, then you've got all the options of either stopping their radiating or resecting cartilage. You also alluded to the fact that the radiology expertise is important. It can be difficult to interpret these images because there's often irregular calcification of the cartilage, which makes it difficult to interpret. And you're only going to see gross involvement, not really microscopic. So that's really where we are. And as you also mentioned, some patients just can't get there. So access is also key. But I'm very happy with the results that we published. But as you said, these operated so dependent as it is for any form of surgery. But it is just one of those niche areas which there is controversy. But it's really about what's your chances of preserving the larynx as opposed to surgery versus radiotherapy. There are some centers where they do suprachiasmatic laryngectomy quite liberally for this. And then, of course, if you get recurrence, then you've still got the option of doing suprachiasmatic laryngectomy. But those are my comments on that. Would you be in Pittsburgh? Any comments here, Julius?
There's only one of our consultants that uses lasers or forces to do things like partial laryngectomy. Most of the others, I think will prefer radiation, if they want to preserve the larynx.
Okay, yeah. As you mentioned, the difficulty if you use radiotherapy, then you're more likely if there is recurrence to end up with laryngeectomy. So from that perspective, the laser often don't use it because of the options available. So that's the big argument in favor of using endoscopic approaches initially.
Thanks, Rob. There are two questions. Dr. Session Harris just asked, are there any studies which have compared local control of open approach versus laser? I don't know.
I love it. Yeah.
So potentially to answer your question, Prof doesn't think so. We're not aware of it.
Have you come across any?
I saw a lot of generalization. I don't think they were direct comparisons, maybe historical comparisons. And I think I remember seeing that oncological outcomes were comparable, but functional outcomes were obviously poorer in terms of domains of phonation and swallowing without aspiration and tracheostomy independence in open partial laryngectomy. And obviously, I would assume it has other kind of unwanted aspects in terms of prolonged hospital stay, often a temporary tracheostomy, etc. And then Dr. Haji asks, so apologies, I believe there were some echoes. What is the time frame for the staged resection? So I did mention it's not one we often use in our unit, staging the resection, but I think some surgeons will resect the involved cord or the lesser involved cord and then wait a month to do the subsequent resection.
Yeah.
So a month is the timing. And then I'll just unmute everyone's microphones if anyone wants asking further questions.
Just to mention that if you're in a country where you don't have CO2 laser, doing open partial laryngectomy is a good procedure to do. And often the radiotherapy techniques in those countries also aren't very. So unless you've ordered your own results and of your radiotherapy, I think it's very reasonable to do an open partial laryngectomy procedure.
And Prof, in your study and other studies where lasers inevitably shown a higher recurrence rate and an increased likelihood of requiring post-operative radiotherapy, one would logically think those are the patients who invariably had cartilage involvement or extension beyond the inner pericardium. I would suspect you're doing a more extensive resection. Because some people have challenged that, if your goal of early glottic carcinoma is one single modality treatment and you're embarking on laser of the anterior commissure, it has a higher rate of the need for radiotherapy, then you're going against that principle as such. But I would assume that the argument to that is essentially most of those cases are in fact upstage to T3 disease intraoperatively, so you're not really necessarily comparing early glottic carcinoma with early glottic carcinoma.
Yeah, remember that about 40% of our patients didn't have radiotherapy. Okay, because the 40%, am I right? It was 60% had radiation therapy. So it means that the 40% of the patients had a single modality treatment. So I think from that perspective, it's good. Is that right? Obviously, yeah.
So only 40%.
Yeah, that's right. So I think that speaks to that issue. When we give radiotherapy, it's often a very subjective matter. It has a matter of someone like Wolfgang Steiner would rather go back and re-resect. He said it's clear he didn't like radiotherapy very much at all. I'm a bit more more liberal in terms of doing radiation therapy when the margins are close, or the pathologist can't call the margin, even though they look clear to me. I think there's a fair amount of subjectivity as to being subject to radiotherapy as well. But the anti-commissure is different to the mid-chord. Because the mid-chord, if you have a margin which is very close, if the patient will come back with follow-up and you can watch it carefully, you might hold up on radiation, whereas if you have a very close margin with anti-commissure, you might be more likely to radiate. If it does recur, then you probably get more, you're more likely to end up using your larynx. So losing your larynx. So it's very subjective often as new subject to medication.
I don't see any further questions on the chat, so I think we'll close today's meeting. Thank you to everyone who attended, and I think we'll see you again next week, Wednesday.